can be really hard to swim upstream against if parents are in the midst of pain, like Pamela was describing, but is a wonderful starting point for us as clinicians to have if we're open in this conversation.
It really is. I want to second what Kevin said about the interpersonal theory of suicide. It really, really speaks to me as well, because I'm all about pain, and it talks about all the pain, and it talks about other aspects. I think Kevin was talking about burdensomeness and lack of belongingness, and then even capability comes into it, which is a whole nother piece that's quite different to us in this field, what capability means. And it's not about access or anything like that. It's a really interesting theory to read, and I highly recommend it. If you don't have it and you've wanted, I probably have a link somewhere, Sarah. Kevin probably does too, that we could get to you if people want to read that one.
Sure.
I'll add another one to the list of myths, and that is that this idea that we need to get folks who are having suicidal thoughts onto medication as quickly as possible, and that's a myth. And the reason that it's a myth that a lot of people don't know, because they haven't read the research on this, is that actually these medications, SSRIs in particular, if we're talking specifically about depression, though there's issues with other kinds of medications, but they're actually known to increase suicide by 2 to 3 times, primarily in children, but also in adults. And so it scares me that one of the myths out there is you better get them on meds and you better get them on fast. And even though the chemical imbalance theory was debunked years and years and years ago, and we have very recent evidence done by unbiased researchers who are not with pharmaceutical companies or others who stand to benefit, who are really looking at the research that was done by those who stand to benefit and seeing that it was horribly flawed in order to get us to buy these drugs. And so that scares the heck out of me, that we're pumping drugs into people. And I'll stick with suicide for now, but I feel this way about other things as well. We're pumping drugs into them thinking it's going to save their lives. And anecdotally, I understand there's always somebody who says, but it did save my life. But in terms of looking at the numbers, the larger numbers, it's taking far, far more lives because we're putting them on medications than if we hadn't, because the medications are causing them 2 to 3 times more to want to take their own lives. So I would be amiss not to say that that's one of the primary, I'd be amiss not to mention the myth of this one, because it's such a myth that I would say it's not even a myth. I would say that we've just all bought it, that it's just the truth despite the research.
And I think that also speaks a lot to, again, I think some of the anxious, like we got to fix something right away. Like it's a quick, easy, like hopeful, trying to be hopeful piece of like, what can we do? What's available? And I think that your point in like, we really got to read the research, really understand what it is, what we're doing with that. Wondering if you have any thoughts about that too, Kevin?
Yeah, I do. It's such an interesting segue too into, I was so glad when Pamela brought up the topic of medication, because I was thinking, man, how am I going to get to a third? Well, like we're hitting so many good myths. I want to do 3 for Sarah. And it did bring up a third, the conversation. And I think you said it perfectly, Sarah, the idea of like, of course, medicine helps many, many people. And of course, medicine can really reduce a lot of symptoms of distress. But when we look at, does medicine just magically make suicide go away? No, we're not finding that. We're finding some interesting stuff with, let's say, lithium, kind of, ketamine, maybe. A lot more research needs to be done on ketamine. But like at the end of the day, if we hold suicide as a response to pain, medicine doesn't magically make our pain go away, just as Sarah mentioned, and neither does, here's my number 3, neither does hospitalization. And it's a conversation, I think, sometimes that we find ourselves having with parents, even if parents are operating from this, I clearly love my kid, I desperately want them to be safe. If they're having a thought, doesn't that mean higher level of care, right? Doesn't that mean they're not safe? And, the reality is many people need a hospital given where they are in the acuity of suicide, right? If they are in a position where they cannot be safe today, right? They don't have the capacity for stabilization today. but they're rarely, if ever, getting pain-focused treatment. You're often getting psychiatric stabilization in that modal length of stay of a day or so. And I think the reality too, going back to something Pamela said earlier, is if we hit the whole range of people coming in, something like in 2021, or something like 3.3 million adolescents had thoughts about suicide. And it was like 3,000 kiddos / young adults 10 to 24 who died by suicide. Which I'm not trying to minimize 3,000, but I'm saying 3 million is a lot bigger. And there's many, many people who are experiencing thoughts, experiencing pain, who don't need the hospital, which I think ultimately is the work that we move in the direction of. It's something that one of my favorite like adages I came up with that I copy and paste and use all the time is I feel like the art and the work is helping parents figure out when does your kiddo need a hug and when do they need a hospital? Because sometimes it's really hug focused, and addressing pain out of the hospital is pretty much always correlated with better long-term resiliency and outcome.
Absolutely. It has nothing to do with the healing that needs to happen so that the youth doesn't have to go back into the hospital. It's really just, symptom management briefly. And, I was reading on madinamerica.com something called Trans Lifeline, naming trans-specific harm in mental health. You can get this on madinamerica.com. And the person that they were interviewing, he was talking about, or they were talking about the transgender hotline that is staffed all by transgender people. And he said, most people don't know that suicide attempts increase after receiving forced treatment, whether that's hospitalization or whether that's being forced to take some kind of a drug. So I found that very interesting because I had not heard that discussed before, and this was very recent that I heard it. So I thought that was interesting. Yeah. I'm not a big supporter of a hospitalization. Doesn't mean never. I don't go with the never, but there's so many things we can do so that hospitalization is not necessary. And since it doesn't actually help in changing things for the future, it just kind of solidifies things in the moment, which can be very important. It'd be better to just avoid the hospitalization altogether by doing the real work that needs to be done, getting into that pain, getting into that healing, and not just managing symptoms. We just have to learn as a field to go deeper, because our outcomes of 30 to 40% success rate in our field are abysmal. So I'm worried about the direction that we're headed.
Thank you for that. Yeah. And also makes me hopeful that we are having panels like this, discussions and education. So really appreciating the work that both of you are doing. And we've been touching about this as well. Like one of the things that make working with youth perhaps a little bit different than working with adults is that we have more opportunities to interact with their family and caregivers, and that plays a big role actually in thinking about the support systems of our youth. Do you have any pro tips around how to engage families and caregivers? And how do you think about the different resources that may be available for youth in your work with them, or in our work with them?
For me, I can't imagine working with a youth of any age without engaging their family. That's just not something that I do. And engaging people who are in pain turns out to be not as hard as a lot of people think that it is. I think it is hard to say in a short panel, but we have got to activate our empathy and understand that the caregivers are doing the absolute best that they can for their kids, even when the things that they're doing we might be able to see as not really helping. But if we can engage our empathy and really connect with them around what's going on at a deeper level, the fear that they're going to lose their kid, the fear that they're doing a lousy job as a parent, the fear that everyone in the world is going to blame them because their kid is not doing whatever they're supposed to do. And we can go in and we cannot be those people who just blame them for what's happening with their kid. And we can be those people who can see that they do love their kid, despite what it might look like to us. Okay. they are trying to do something helpful, then I've found that people engage very, very quickly when I approach them that way. I think they're not used to being approached that way. They're used to being approached in kind of a clinical or, kind of, what have you done wrong here, without maybe using those words. So I have heard people say those words to parents and caregivers. Then people run a mile a minute the other way. We also have to be able to tolerate that when people are in pain, they often come out pretty combative and angry and aggressive. That's just how it is. But we have to remember that that's what it is. There's pain underneath the negative kinds of behaviors on top. And again, if we don't join in that power struggle, get, angry back, and just really listen and reflect and empathize and understand, I've found not only do people join, but they're willing to come back the next week. And before you know it, they're willing to come back the next week. And then you're doing the work. So I think that's the best way for me, Sarah, to just kind of kick it off.
I like that answer a lot. I think it's one of those beautiful, simple, not easy psychology answers of like empathy, right? It all comes back to empathy. And I agree. And I'll acknowledge, I think it's a really hard one to put into practice for a lot of reasons, right? Some that Pamela already mentioned, like sometimes we see clearly problematic behaviors or neglect, but looks to neglect, emotional neglect to us, or things like this, where it's hard to get in a parent's corner. And other times I think it's hard because we shouldn't be, given the nature of the role that we're doing, right? It gets really interesting depending on what role am I playing as part of a team or as part of healthcare for this family? Because I think that the amount of empathy that I want to really express and hold, and the amount of support I want to offer parents, probably looks quite a bit different if I'm in the role of a family therapist versus this kid's individual therapist. And that doesn't mean, like, I'm not trying to say that we don't want to express empathy if I'm in the individual therapy role. But I think it gets kind of tricky, as alluded to. It gets kind of tricky to say, hey, I am really in your corner, right? Unapologetically, fully in your corner, biased and happy to be so for you as an individual therapist, but also stepping out of your corner to do a lot of work soothing mom and dad. And I think where it starts becoming a really tricky and challenging conversation is, how do we hold those lines? How do we engage parents enough? And I could certainly tell you that the CAMS idea is one option, but how do we engage parents enough to show up for their kid and support the individual work without having it feel like I'm your agent, parents, or we're having too many side conversations, or I don't know what's being kept secret from parents, or like I'm trying to enact the parents' shoulds or the parents' views of why I'm in pain in the first place. The empathy is so great, and it's hard to implement, especially depending on the role we're in.
And what's nice about a panel is that you have people that approach the work differently. So I'm going to throw a different slice into it. I'm the individual and the family therapist always for the same client. It's just how I've been doing it for decades. And what I've found is that when I have empathy for everyone at the same time, the kid actually responds very, very well to that, because down deep inside, after they've told me how much they hate their parents and never want to see them again and say all the lovely things, and after the parents said they never follow any directions, take them away. Okay. All we have to do is go a little deeper to realize that they all want exactly the same thing. The kids want to be appreciated and want to feel the love from the caregivers. The caregivers want to figure out a way to be respected and know that they're loving, that their kids know that they love them. And I've never, ever found a conflict of interest, because my client's the same client, whether I'm sitting with the youth alone, whether I'm sitting with them with a parent or a caregiver or siblings. I haven't lost fact of who I'm being paid to provide services to, because that's the person who's come in with the symptoms that the teachers or the caregivers or the PO or the county social worker want somebody to fix. I don't do any fixing, of course, but I have never forgotten that this is the person that got referred, because they're the ones who are demonstrating the symptoms that tell me that everyone in that family is in pain, and they're the ones who are raising their hands about that. So it's just that's just never been an issue for me. And I've been able to facilitate everything with everybody in the room all at the same time and have people feel that therapeutic alliance with all of them together. And they want to come together, and I'm going to leave at some point. I better leave at some point, and I'd like them to carry on without me. So that's just a difference in style of working. And I've just found that to work fast. I'm real attachment focused and trauma focused. And so I can do a lot of work quickly within a short time. And this is an important conversation, because for me, I believe that youth who are thinking about taking their own lives or attempting to take their own lives, or sadly have taken their own lives, I have never ever heard of a situation with a youth or an adult for that matter, where it didn't have something to do with their primary relationships in the world, not feeling them, not feeling wanted by them, feeling overwhelmed by them, whatever it is, and seeing suicide as the only method of escape. So I'm all there for everyone all at the same time. Again, just different styles of working, but I didn't want to throw those out, not throw those out.
Well, no, it's fair. And I think the idea of exposing people to a couple of different styles, that they're maybe vetting their own and figuring that out, makes all the sense in the world. You know, the CAMS style, the collaborative assessment and management of suicidality style, holds a lot. There's like a Venn diagram overlap, I think. And I think what probably comes through most of the time when we get our different stylistic considerations is, as Pamela mentioned, right? Empathy, right? Empathy for you, empathizing your pain. There's this big concept of empathize with the suicide wish, you know, like not condoning it, but saying, of course, if you feel trapped, suicide would come up as an option. Empathy, empathy, empathy. And how do we get there? You know, in the CAMS approach, the stylistic difference is kind of a bit more like this: is CAMS is a very individual therapy, where it's very clear that my opportunity and my priority is the safety, the stabilization, and the pain of this kiddo. And we have open conversations with parents, but it's gated in a way. And in the sense of, again, we're saying up front, I can't have a conversation with you that your kid doesn't know about. You know, any conversation, it would be awesome if we could share this together in a very team-focused way. But if not, if that's not possible, right, we want those doors of communication open. And we regularly have communication with parent and kiddo together around supporting the treatment, which often takes the form of, at least initially, a safety plan for the parents, where we're working with parents around how do you make the environment safe. We're working with parents around what are the skills you need to do before approaching. How do you make it safe to feel like you can be approached, and that, you know, again, if your kid needs a hug in a hospital, how do I know what's the plan I follow to show up right? And there gets to be this interesting line where in the process of supporting, there's going to be some stuff coming up where we have conversations, like we need to shift into different things. Like, as an example, off the cuff, Pamela earlier mentioned some of the research around affirmation in the context of transgender identity. If we have a transgender client coming in saying that parent affirmation is the reason, or lack thereof, right, in affirmation, is the reason I want to die, eventually what's going to be wonderful and probably necessary is a conversation within the system around, how did this happen and what's going on? You know, mom, dad, what are you bringing to the table? What are some of the messages you grew up with? What are you struggling with? What are you potentially grieving? And what is that like for you, kiddo, in the context of the system? It's a beautiful and lovely conversation. Stylistically, where CAMS typically goes is we say, that's not our conversation, though. Because for that conversation to work really, really well, you don't want someone who's only agreeing with dad, where you want somebody who's unbiased. And I'm sorry, but I'm already biased and I don't want to change it, right? I'm already all in on kid and how we all show up and support kid. Again, I agree with Pamela, not saying that there's one that's objectively right or wrong, but it's cool to get different, you know, different styles and different approaches so that you can ultimately come back to Sarah's question around what is the role that I'm playing here? Because I'm probably going to engage parents very differently depending on the parameters of the role that I'm in.
Really appreciating that, and also wanting to open up some of the thinking around the roles, because we may have folks coming in who are not necessarily in the role of a therapist, family or individual, and maybe coming in as, you know, like a school-based or school administrator or a teacher, or knowing that they too can be identifying, oh, this is a kid who needs help, this is a kid who's really struggling, and thinking, and just like having that framework around thinking of like this youth isn't living in a vacuum. This youth is embedded in a family, it's embedded in a school, it's embedded in a community, and finding ways of engaging not just the family, but also for the purposes of safety planning, for the purposes of engagement, for the purposes of like watching where is the pain that's happening here, and how is that impacting the youth, and how does that contribute to the drivers that are happening, to use Cam's language. Really appreciating that. I'm also recognizing from the first question in the some of the myth busting that we had, and beyond too, there's really a piece of hearing, our own reactions that come up in working with youth, and how that impacts the ways in which we might intervene. And I have often, even for myself, have felt like worries or fears, or like I want to, like this, almost like I want to have this reflexive, like, let me make this right for you. And any thoughts or tips around helpers of all the roles, around how do we manage our own stuff so that we can stay present and available for these young folks?
Awesome, wonderful questions. I think I'll start with the first one that you asked is, what are the considerations essentially for different roles and different adults in someone's life? And I think that's a perfect, difficult question, because I think that there's so much that depends on what specific adult are we starting with. Like if we had, let's say, somebody on the line right now who were a teacher or a coach, and you're looking out for a bunch of different kiddos and trying to see what's going on for them, versus, let's say, I'm a parent and I want to bring in other supports for my kid. I think there's probably slightly different answers here. Some overlap, like for me, if you're in either of those groupings, something that I think is really cool to be aware of is some of the literature out there on what they call warning signs of suicides. There's tons of really effective gatekeeper trainings, things like QPR, et cetera, et cetera. And also some things around this concept of warning signs, which is, there's some stuff like withdrawal, like anger, like anxiety, sense of purposelessness, sense of hopelessness, right? Substance use, where if you're noticing an increase in the past couple of days, past week or so, something could be going on. So drawing our attention to that, calibrating our radar for certain things, I think is really helpful, because it opens up to right what Pamela said in the beginning. It's cool to ask this question, especially if I feel comfortable asking this question in a way that invites conversation. Not like the client Pamela mentioned, where it's like, if you're just going to do this, get it over with. But like hey, I'm wondering how you're doing. What's going on? What are you thinking? What are you feeling? Help me see what's up for you. I think that's great, right? Warning signs and a willingness to ask the question without shame or blame. And I think if I'm a parent and I'm looking to bring in other people, other adults especially, to support this care, I'm kind of vetting a couple of different things here, right? I'm vetting, much like on our safety plan or one of the safety plan templates, are there adults, are there loved ones, aunt, uncle, older cousin, something like that, that are useful as people for distraction? I could call you up to talk about how heartbreaking my Notre Dame team game was last week, or the Loki season that's coming out next Friday, or something like that. Are there people who you actually would be willing to share pain with or share risk with? And how do we have them come in and essentially do the same kind of coaching for them like we would for parents around, what are some things to say? What are signs that it's time for the hospital? Et cetera, et cetera. There's a lot of coaching that can be done. I think the depth of it and what I'm showing up for this kid is going to be different depending on if I'm showing up as part of a safety plan for an individual, or just looking to be on the lookout for warning signs for a broader group, again, like a coach or a teacher.
Absolutely. Sometimes I've heard people say as one of the myths, well, there were no warning signs. It was completely out of the blue. And yet that is a myth. There are warning signs that we may not be tuned into those warning signs, so therefore we don't see them as warning signs. but they're there. So I agree with Kevin. I think the more that we can educate ourselves and learn what some of these warning signs might look like, especially the really subtle ones that can very easily fly under the radar and not be detected. And then people really think, well, there was nothing wrong. They just suddenly wanted to take their own life. When that's not the case. So I think that's a really great thing to tune ourselves more into so that we can be aware of that. I also think that if we're working in this field, I started off as a residential counselor in high level residential treatment before I decided that I fell in love with the kids and wanted to go back to school and, actually just go into other areas of the field. But I've always hired people in all roles, whether they've been peer helpers or case managers or care coordinators or parent partners or peer all different roles, because that's what we do in this field, right? And my emphasis is on kids in the system of care. So that's how we do it. We wrap around them, so to speak. I think that when we do that kind of work, especially when we're looking at something like suicidal ideation, we can get pretty darn triggered. Most all of us have had loved ones of one sort or another who have felt this kind of pain in their lives, or perhaps even taken their own lives. And I think that when we're close to this kind of pain, if we haven't really become in touch with our own pain, and we are working in this field, then we can very easily be blind to, surprisingly enough. We can either be like overly invested in the pain and we're just getting so triggered in it because it's bringing up our own stuff, which we often don't know that that's what's happening, or we can even push it away. And a quick example I have was a residential counselor who was working with a 16-year-old girl, and the 16-year-old girl whose life sucked, she was in residential treatment, would say to her sometimes, I hate my life. I wish I were dead. Well, this residential counselor would say, stop talking like that and walk away from her, as if she was just going for attention. As it turned out, that residential counselor had lost her sister to suicide, and she got angry when she would hear a 16-year-old say something like that. It's like, you don't play around with that. You don't act that way. Unfortunately, in that moment, when that 16-year-old was saying, I hate my life and want to die, and I have no doubt she did hate her life and did have moments where she wanted to die because her life was sucking in that moment, I would guess that having your residential counselor be angry with you and walk away was another abandonment, another pain, which could have inadvertently made her hate her life even more. So this residential counselor, thank goodness, got support from her supervisor so she could identify what was her stuff versus what was her client's stuff. And then she could be there for this client instead of pushing her away. Okay. So I think we owe it to ourselves, if we're going to do work in this field, to do our own work, whatever that looks like, so that we don't get scared, overreactive, et cetera, with any of the pain our clients are struggling with, but especially the big ticket of suicide. I think that scares probably all of us more than about anything in this field, is that we could lose a client and then wonder, how did I miss it? How did I miss it? Just like anyone would feel. So
I agree. I really agree. I think the idea of getting support for ourselves in this work and not underestimating the cost of doing this kind of care is so important. And, the reality is that clinically, it's basically always the case that we would love, if at all possible, for parents and caregivers and people who are showing up to support to get their own support too. Right. And it's so hard because it's so easy for us to be in a position where we're working with an adolescent and parents are talking with us and talking about what's going on with them. And we want to soothe them so that they show up and they're better care. You hold a lot, but you do need your own support as parents. And sometimes, even if parents are unwilling or unable, maybe financially, maybe logistically, unable to pursue therapy services for themselves, sometimes it's even just a matter of, if you're going to show up for your kiddo, can we coach you on how to take care of yourself to do that? Even if it's just a mirror, like on the safety plan, before reaching out to other people, we're asking our clients to do some internal coping. Parents, before you reach out for support, Is there any coping you want to do for yourself? What are strategies that could bring you down so you don't feel like, oh, my kid's life is on the line, or, oh my God, I can't believe I have to do this again. I'm pissed. But that we're showing up effectively, essentially putting your own oxygen mask on before someone else's. So the idea of self-care across the board, I think, is a beautiful runner, whether I'm showing up in the perspective of a healthcare provider or a residential counselor or a concerned parent who really just wants to show up when I need to show up as well as I can.
Really so important. And just recognizing that we have roughly about 10-ish minutes left, and I want to move us forward into our last question and then open it up for others as well. Are there other resources or trainings that you would recommend?
Well, of course, I'm going to recommend my own training on suicide in youth. But other
For
than
sure.
that, the best resource that I have found to keep myself truly informed on unbiased research in this field, the research that what really tells us what's happening with the medications we're prescribing, and I just think it's very, very important that we know that placebo, I'm reading this right off of a slide, placebo-controlled studies do not suggest an increased risk of suicide using these SSRIs. They prove it. And additionally, these depression drugs increase aggression 2 to 3 times, which not only leads to suicide, but also to violence and homicide. This isn't like, well, gosh, these medications certainly don't do anything to address the pain, so therefore we really have to go deeper than that. I want to do that for sure. But these medications are actually killing people. And I'm worried about that. So I just wanted to stress that that is what the research is showing. So the research I would suggest is going to maddenamerica.com, type in whatever you want to know there. It has the largest database of science, I believe, in the world that has to do with our field. And they only present research that's done by unbiased researchers. So, you're not paying for big pharma or for something else. They do take that research and they do analyze it and tear it apart basically to show us where it was biased in nature. And so that is my go-to. It's free to be a part of it. And you can type anything into the search you want. It can have to do with medications. It can have to do with anything that you're interested in. And some really great articles will come up, and they are written by professionals in the field. They're also written by clients in the field. And so I love getting my newsletter once a week. It's my go-to thing. It's like, oh, yay, my Madden American newsletter is here. So it's very, very, very informative. So that's one of the resources that I would recommend.
I look forward to checking that out. There's probably a few out there. I think Tom Joyner's work on the interpersonal theory is really great, as Pamela already mentioned too. That's a wonderful thing to look into, just in terms of like what's one of the biggest theories, most widely accepted theories for the pain that people are in, whether we're having thoughts, whether we're engaging behaviors, et cetera, et cetera. If you're a clinician on the line and you're interested in kind of getting up to speed for what we can do or what I can bring in, if you're a family therapist, I'll encourage you to check out attachment-based family therapy, right? Guy Diamond. That's something that I would recommend pretty highly. If you're an individual therapist and you're looking for something, you have a couple of options, right? So DBT is something that's been shown to be really effective, as have the cognitive therapy protocols. So you could look up cognitive therapy for suicidal patients. And then CAMS, what I'm a trainer for. CAMS is an individual therapy approach, as I'm sure you're sick of me mentioning right now, but it's one that's really centered around essentially doing assessment and safety planning to get to the pain and ultimately ideation. It seems like when you compare the data we have so far on CAMS versus DBT and the cognitive therapy protocols, those two are really effective. The cognitive therapy protocols and DBT, DBT has more studies as an evidence-based suicide treatment than anything else. They seem to be especially optimal for behavior change, for reducing suicide risk of attempts, right? Giving you the skills to act differently. CAMS is not effective for that, but it seems like CAMS is ultimately probably more optimized for ideation and changing suicide ideation, getting at the pain that makes you feel like life isn't worth living, and ultimately like what are we moving in the direction of. So I would encourage you, those would be the ones if you said, hey, I want to deep dive into different treatment options that are available. Those are the ones that I would recommend you check out when you have the opportunity.
And I guess I put in the chat, so I'll just add that I also love attachment-based family therapy. Guy Diamond and I have very, very, very similar thoughts on attachment and healing and ruptures and all that stuff. But my theory is called PITH, Pain in the Heart Healing. And I put into the chat the book that goes with that, which is Speaking from the Hidden Heart, Helping Families Heal. So I love anything that has to do with attachment, healing, and family relationships. They go together well.
Really, really great. I'm seeing in the chat that there's a number of folks saying like, can we have a written list of all of these wonderful resources? And I would also really like to make sure that that is available to you. I think if you, there's a couple different ways that we can do that. I can add my email into the chat. If you want to have written, I can send resources to you via email. And then you would also have my email available as well. That I can do that. And Pamela and Kevin, if you wanted to add in your contact information, that would be totally up to you as well. If
Sure.
You're interested in further.
Absolutely.
Yeah. I also wanted just to let folks know that we do have an evaluation. I want to get to questions, but Catherine will drop a link into the chat with the evaluation link. If you have a chance to copy and paste and get that out at the end, that would be great. And that's the evaluation form. And are there, Catherine, were there particular questions that you had noted in the chat that you wanted to?
I mean, there aren't that many. So I think around Stephanie asked a question within the context of when Dr. Parkinson was talking about how she works with the individual and the family. And that's been her practice. And so I think Stephanie was asking, what about in family systems where there's abuse and suicidal ideation? Do you experience a conflict of interest there? And Stephanie, feel free to chime in if I didn't get that context correct. But
Is
I think
that right, Stephanie? That was okay? I don't find there to be a conflict of interest. And in fact, I find that those kinds of symptoms within a family to be a stress call for saying, just like a youth symptoms, I find those kinds of behaviors in families to be a call for help. We don't know what to do. We're out of control. And so I want to go right in and I want to help them with that. And I have not found any kind of conflict with alliance with the youth or anything like that. The youth I work with, they want the same thing I want. They want things to be better in their family too. And if I started to work with them in a way that seemed like I was leaning towards them against their family, they wouldn't trust me anymore, because they're not really looking for just a relationship with me. They're looking for me to help them have the relationships that they would like to have with their families. And they've usually lost hope that that can occur, but that's my job to help bring hope back into the room. So without, having a whole training on, why and how and all that stuff, that's my quick answer to that one.
That's helpful. I just, with our mobile crisis teams, a lot of times we're experiencing kids that we don't know that well, right? And what we're learning is that there's been significant abuse, like sexual abuse, and the kid is saying, I want to kill myself because of what happened. And so it's definitely hard to align with the abuser in that situation and also intervene with the child in that moment. Now, these aren't situations where we're doing long-term therapy in a family system. We're intervening. And so I'm always pulled to come to the rescue of that victimized child and know that there's reasons how a family gets to that point, but definitely feel more aligned with the child than the abuser. That's just, yeah.
It's definitely, we all want to align more in that direction. I think it's possible to do both at the same time, but it does take practice to do that for sure.
But it might be, oh,
Yeah,
sorry.
go for it. No, go for it.
But I think, you know, aligning with both at the same time, absolutely agree. It takes practice. And it might be the case that there's also a question of timing as well, right? Because in the capacity that Stephanie is talking about, I absolutely do think that looking at safety as a first priority is really important, and making sure that the environment is safe. Pretty much every suicide focused approach with evidence base behind it, you know, the randomized controlled trials, all that stuff, really centers around the idea of, first and foremost, our priority is making sure you're safe. And then not just that the environment is okay, but that you yourself have the capacity to be stable, right? That you can act in your own coping, the crisis management stuff that I'm sure, Stephanie, you're doing quite a bit of. We need that in order to get to pain. But I think right away in the context you're describing, you know, absolutely looking into what are the threats to safety, not just suicide, but abuse and beyond that in the environment. I think that very much is the right prioritization. And then, you know, assuming we're in a position where we have a safe environment, we can move in the direction of the pain, whatever format that is, right? Whether I'm the individual therapist and we have a separate family therapist, so you know you have someone in your corner that can help you when you have these conversations over here, or whether you're in a role like Pamela's describing, where you're wearing a couple of hats at once. But I think you're absolutely right. We have to look at that safety first before we do anything else.
And I apologize if my response sounded like I wasn't doing that. I always consider safety first. Working in the positions that I've been in for all of these decades, I'm in a hospital setting. Where I've worked, our residential treatment, non-public school, these are all settings where safety is primary, and I can do both. I can prioritize safety and I can go in and start that healing process. It takes practice, but there are ways to do it. Absolutely, those safety first. I just wanted to make sure that I said something about what Simona wrote there. And yes, I agree with you, Simona. That's all I have to say.
Can we read out Simona's comment? Is that okay? Or I will. Okay. Do you see a difference between mental health and emotional well-being? Is that the comment?
The second part that Simona wrote.
It seems a lot of what we consider mental health struggles are actually emotional reactivity.
Yeah, to the world around us, right? Discrimination, oppression, what's going on in our family systems, community violence, et cetera, et cetera, et cetera. You know, these things cause depression. These things cause anxiety. We know it's not a chemical brain imbalance that causes it. That's been debunked years ago. We know that it's not, biology that causes it. So what causes it is what we're experiencing in the world around us in those relationships. Those are the primary causes of it, which is another reason why we want to be very careful with what we're doing to our brains with other manipulations.
I appreciate that. I'm recognizing that we are out of time. And this has been such a great and excellent conversation, so packed full of information. I just really wanted to thank you both again, Kevin and Pamela, for joining us. And if folks, all of the, I think, emails are in the chat. And I am sorry, Idris, as well. Certainly I'm happy to touch bases with you, and also if Pamela and Kevin want to have a connect in as well around your comment. Wish we had more time.
I know.
Yeah, I think that is a really good one. And please feel free to offline us, because I don't think we do spend enough time talking about cultural considerations in this broader concept that we're taking a look at, and how really cultural humility has to be the perspective that we're looking at everything through, even something down to the lens of what is your individual experience in terms of the culture that is the context for pain. So please, yes, I feel like we need a whole other webinar on that, but please feel free to shoot a message at any point. I'd love to tell you about CAMS or about where we are on that, if at all helpful.
Yeah, I totally agree with that. The time frame was really just meant to touch on a few little things. In my youth and suicide training that's coming up in December, we have 7 hours and we go very deeply into culture and suicide and its impact and all that stuff. But it's very difficult to do that in, less than an hour on a panel. So, but we got to scrape the surface, right, of a few things.
Yes, absolutely. Absolutely.